Well, thank you very much. It's certainly an honor to be here, and I've really enjoyed learning about IORT while here. I trained at an institution that had a dedicated OR next to a LINAC for external beam IORT, but currently practice at a hospital without an IORT system, and so it's been certainly interesting to hear updated perspectives on sort of newer techniques for IORT. I was a little concerned about being in the controversy section, so I'm going to give you the overall overview of sort of a natural area for us to get into in terms of using our CT on Rails unit to support HDR-based IORT. It's something that even during my first visit during the interview process for UVA sort of seemed like a logical thing for us to do, and I'll share with you one detail why that seemed quite obvious. I don't have any disclosures. I would like to say that my own personal opinion, just so people don't lob shoes at me during the question and answer section, is so I do think that my former resident and I recently published this commentary, just sort of reminding us all to be aware of our own professional biases and our favorite modality and how we appraise evidence. And I share some consideration that maybe the guidelines could be more favorable or more favorably worded for IORT. We feel the same pain in terms of reimbursement, which I'll also talk about later in terms of guidelines implications for those discussions. So the basic outline, I'll tell you a little bit about our technology and why it really made sense for us to push IORT as really our premier research program within the CT on Rails facility. Let's explain our rationale for why we got into this area. And then I'll present to you just sort of summary bits from the research that we've done so far and talk about our completed phase 1 feasibility and safety trial, which we've published, and then the current status of what we're calling IORT-2, which is a phase 2 single-arm, 2-center study. So the CT on Rails unit was installed into the new cancer center when it was open in 2011, when UVA radiation oncology moved from like a 1950s facility in the old hospital with exposed wiring to this beautiful new cancer center. I came to UVA in 2012, and my job was to really build up the HDR brachytherapy program. The original idea was actually came from the GYN perspective for why UVA installed this in the first place. We have a very amazing and persuasive GYN oncologist who was professor emeritus at that point, and he said, we have all these women that come from Southwest Virginia and they drive hundreds of miles for their cervical cancer brachytherapy. Let's create a system that uses pretty standard approachable technology with the same sort of equipment, but can serve a very large volume of patients and get them in and out and back home more quickly. And then practically speaking, we have a very small clinical team. For a long time, for the first 2 years, the brachytherapy physician team was me. So it's a very small team, so we need to be able to leverage our personnel that we do have. The suite includes 3 recovery beds, which is sort of anesthesia's turf. We have treatment planning consoles, 2 shielded brachytherapy delivery rooms, one of which is a small room that we practically speaking use for storage now, but it is shielded and separately cabled to deliver HDR brachytherapy. And the other one is a beautiful dedicated brachytherapy suite that has anesthesia capability on both sides of the room, which gives flexibility for positioning as a CT on Rails unit. And of course we have every version of ultrasound. Notably, we do not have MRI in our building, but this is what we have. So this is an image of our suite. Notice the anesthesia cart in the background. It's actually, we're in Charlottesville. UVA owns a big chunk of Charlottesville. It's a huge footprint suite. We're lucky to have it. So there is no shortage of square footage in this area, and indeed in the entire floor that's devoted to radiation oncology. You do get all your steps in a day in our department, I will say, which is challenging for patients sometimes. There are some OR appearing elements, but it is definitely not an operating room. There's a sink in the room, which is not shown in the picture. It's a sort of porous faux hardwood flooring, and there's not the OR type ventilation system, so we really are not classified as an OR, which is an important detail. So our emphasis for our program, and we try to stay committed to this, is to maintain a priority on efficient workflow. So we leverage our existing system to do all steps of the procedure. This is for all brachytherapy that we do, with a scan, plan, treat workflow. So you place the applicator, do the CT scan, do the planning, treat the patient, and if the patient's under anesthesia, they wake up and everything's out already. Our suite lends itself very well to cases under anesthesia, such as like interstitial cases or intraoperative radiation therapy was sort of an obvious thing. So our rationale, or sort of motivation for doing brachytherapy-based breast IORT, as you think about that time, like 2012, the reaction was like ongoing for the Target A trial. We knew we had this unique integrated image-guided brachytherapy facility where we can essentially use APBI techniques, like we use a single-entry balloon applicator in standard CT planning, and leverage that to offer our form of IORT. We knew that we only had a little bit of wiggle room in terms of what could be potentially approvable by the medical center administration, which of course is very risk averse. And so lumpectomy seemed like an appropriate way to start. And there were still a lot of roadblocks in that way. So we also viewed HDR brachytherapy as a chance to address some of the technical criticisms of the Target method, which we had read about. None of us had any experience in using that, but it's something that we had read with interest. So one role, and we hadn't yet shown it at this point, but if you're familiar, if you use HDR brachytherapy, you know that you're going to get more coverage of what's deep to the applicator, so we just get more depth dose. So we felt like with maintaining the same applicator surface dose, that our dose at 1 centimeter beyond the lumpectomy cavity, for example, would be higher. So we could address criticisms about the low dose to 1 centimeter beyond the lumpectomy cavity. And we had a modality that, of course, there's innovation within IORT where you can use other imaging tools, but we had a CT on rails unit, so we could use it for verification of applicator placement and for customized treatment planning. And the applicator we use for brachytherapy, although it's a single entry device, is a multi-channel applicator. So we knew we could shape the dose, and in doing so, get to a higher dose. So that was sort of our rationale. The other things that it really helps when you're doing something collaborative to be married to a breast surgeon. So the woman next to me is my wife, Shayna Showalter, who is the lead breast surgical oncologist for this study. And so in the early stages of this, it was primarily modeling studies to get this going with the medical physicists and I. And then now that the trials are ongoing, she's leading the program. So it's worked out well. And it's a natural fit when she bosses me around as the PI for the trial. So it just feels right. I don't know. So this program has grown into a sort of a mixed research and clinical innovation type program at UVA. There's a component of this, so we have funding from the health system with a mixed clinical sort of marketing type goal in terms of getting more patients by offering a patient-friendly clinical service, and using in sort of furthering our research mission, which also, as you know, at academic medical centers, serves to distinguish the medical center from local other hospitals and can sometimes draw patients. So this is a sort of marketing-ish slide that was part of that. That's the caveat for that. But here's the basic gist in a sort of non-scientific sort of for administrators type view. So it is a cardiac sparing method, not as cardiac sparing as Target, but it is cardiac sparing compared to external beam. By using a multi-channel, multi-dwell position approach, which is a standard breast balloon applicator commercially available, we can shape the radiation dose away from skin and ribs. We have CT imaging, which is very helpful in terms of verifying applicator positioning, which I'll speak to more later. And we have the ability, through using an iridium source with higher depth dose, essentially, to cover at a higher dose to a centimeter beyond the applicator. So we're sort of thinking at this from a breast brachytherapy perspective. So ultimately, if our prescription dose is 1 centimeter beyond the applicator is 12.5 gray, we give a 20 gray surface dose, which was sort of inherent. We assumed that a priori when we started the process. So our development steps, we had a dosimetric study first, which I'll tell you about. We had a whole mix of tense hospital discussions and vetoes popping out from every corner, ultimately, and then staffing and dry runs, which I will not tell you about, but if you ever want to get a beer, I'd be happy to tell you all the steps. And then we conducted a phase 1 trial, which is now finished and we've published. And then we're in progress with a phase 2 trial that has an efficacy endpoint. So the dosimetric planning study, so this was published in Brachytherapy. It's a really basic treatment planning study. We had a sort of medium volume APBI practice at that point in conjunction with the breast surgeons. We went back and looked at the prior 14 scans from our patients who were treated with single entry balloon brachytherapy at our center, and we just did a computer modeling study. I mean, it's pretty, to radiation oncologists, the sort of stuff that we're doing, and this is like a the normal sort of physics-based projects that a lot of residents would do, for example. So we basically modeled what could we achieve with a multi-lumen balloon applicator using HDR brachytherapy compared to a 50 kV unit. And then, so the first part was comparison with a standard dose. The second phase of the project was, if we set as our goal to have a 20 gray applicator surface dose, what can we give to a PTV eval volume, which is a APBI term for essentially what's deep, what's 1 centimeter away from the applicator, the basic gist. So this is a big table I've got in the red box here that what drives the expected difference, and this was sort of we assume all these things you could have predicted before the study, but of course we get more coverage to 1 centimeter from the applicator. And the reason why is mostly related to it's a higher energy photon that's coming off. The gamma rays are higher energy. And the basic concept is that the iridium source will have a predictably higher dose homogeneity index. It just means that dose gradient's a little bit smoother. Now, this was expected, but it was helpful for us to show it. The downside is that we do give a higher cardiac dose, so we showed that as well. I mentioned that in our paper compared to a target method. But it's still low compared to other radiation options. For our dose selection, we basically, we had to pick this, no one has the right answer for this, but we basically wanted to have the same applicator surface dose and not to exceed that, because our interpretation was that at least said something that the 20 grade of the surface was something that we shouldn't push. And so we ended up arriving at being able to consistently deliver in all of those 14 patients, which granted is not a huge set, deliver 12.5 gray to the PTV eval in APBI terms for that. So we picked that as our dose for the pilot study. And that launched the program. So after that, we really launched a clinical program where every patient is treated on a clinical trial. So that's the nurse there is our lead brachytherapy nurse. There's also a little bit of infrastructure attached to this overall program. As of Friday, there have been a total of 207 patients who've been treated with this method, 30 of which are at Thomas Jefferson University and the rest are at UVA. We completed a phase 1 trial. We had 30 spots, as you'll see, but we treated 28 patients in the end because of consent forms and stuff. And I'll show you results from that. And then we have an ongoing phase 2 clinical trial, which has an efficacy endpoint at a 5-year time point, which was based on recurrent whole breast radiation recurrence rate. So it's designed that way. And so this is our team. I don't know what they're doing in there. For the first couple, I was in the room, and I get a little queasy around real cases, so I now stay outside and I wear street clothes. But they're doing something in there, putting the balloon in. And this is our physicist. It just shows the point that there is a fair amount of extra time for customized treatment planning. So this is done in standard commercially available brachytherapy software. But in the beginning, it was taking 30 minutes to plan the case. Now we're much faster than that. But it is a extra step in the process related to using CT. So single arm study, We had approval for 30 patients. We basically set it up to include astro-suitable and cautionary patients. And brachytherapy had to either be delivered at the time of surgery or within 30 days, and there was both sort of pre and post pathology cohorts were allowed, and all steps were performed in the brachytherapy suite at UVA. So the surgeons come to us. And this is the basic idea for the trial. The basic gist is that if someone has a positive margin or a unexpected positive node, then they're recommended to have whole breast radiation and other stuff that follows from that. Practically speaking, because of patient decision making, like their need for their decision about radiation, at least in our workflow, often depends on their margin status or lymph node. So most patients in the end opted to be treated in the post-pathology cohort, so or have a re-excision lumpectomy at time of applicator placement. So our primary objectives: feasibility. We define that as the ability to deliver radiation within 90 minutes from the time the applicator is placed to the time treatment's over. That there are a lot of variables there, including how hot your source is. So there are some challenges for that. But we felt that was important because otherwise no one's ever going to do this if it takes forever. And our surgeons certainly wouldn't sit with us for that any longer than that. And then we wanted to follow safety as well and establish that it was safe. And then we had secondary objectives. We're collecting blood to look at some immune endpoints, ultimately, cosmetic outcome, and patient-reported quality of life. So we showed, and this is published now, we showed, and there were 28 patients included in this report because 2 patients we lost their spots because they were like consented and then ultimately changed their mind essentially. So they were never treated. We're reporting everyone who was treated. So the median time from applicator placement to applicator removal, or walking into the room for applicator removal, was 67.2 minutes. And 26 of 28 patients were treated within 90 minutes. And that was our main feasibility criterion. Interestingly, and that we described this, sort of the events in the paper, both of those patients who had longer treatment intervals had multiple CT scans because the first CT scan identified like suboptimal applicator position, and so there was clinical action that led to a subsequent CT scan. So it was potentially valuable information that we discovered in those 2 patients. Safety, we had 2 grade 2 toxicity events, like more significant skin reaction, all soft tissue stuff. We had no grade 3 events. So we also, in looking at the trial, one of the other things that we wanted to focus on, because I think this has more global implications and not just related to brachytherapy, but also thinking about how certain it is that you're getting good placement when you're doing an applicator insertion under visual placement. So these were all placed by breast surgeons during the procedure, all of whom had prior APBI experience, because I set it up so that the surgeons did the work when we were doing more APBI. So 7 of 29 patients had an issue identified in their initial planning CT that led to clinical action. And I'll show you a couple examples of those. But basically it was suboptimal applicator repositioning, a very large air cavity that led to poor conformance of the lumpectomy cavity. And we have an updated look at with more patients, and it's only down to like 1 or 2% lower than that even. So it's not really just a learning curve. It's that you really, when you have the ability to look at the deep edge of the lumpectomy cavity, you may find that the conformance is not as ideal, which is certainly very important for brachytherapy, maybe important for other things as well. One of the examples from the paper was re-excision for a clip. We would have found that out eventually anyways. We were able to tell the radiologist what she was going to tell us when she called us. So this is 2 examples from the manuscript. We have 3 total included, and you just see that on the left is the before and the right is the after. So we did correct for this air pocket. It's a big deal, I think, for brachytherapy, and if you can see it on CT scan, you're going to want to do something to change it. So these are examples where we either use the vacuum port or did one time the surgeon did a tissue transfer. So we're now in the IRT2 trial. So we have the IRT1 showed safety and feasibility. We did the IRT2 trial design. So there's 290 patients total. Everyone gets the same treatment. We did include a second site, not only for pace of accrual, but because one of the concerns is that people could say, well, this can only be done at UVA because you have a CT on rails unit. So our second site, which is where I was faculty before, is Thomas Jefferson University, and they have a distributed workflow environment. So they actually don't do this in an integrated suite. So you could say, well, then it's not IORT, and that's a fair point. It's same-day, single-fraction HDR brachytherapy. So fair consideration, but I think it lets you view this trial from two different perspectives and really does tie to IORT and HDR together. Primary endpoint is 5-year ipsilateral breast tumor recurrence rates tagged to the whole breast irradiation arm of target. It's sort of how we designed it to show that has similar rates. And then we have a companion study for 50 whole breast irradiation patients because we think that one of the potential angles for focused radiation like this is potentially avoiding some immune suppression. I don't know if you followed the story, but there's some concern about lymphopenia with conventionally fractionated large field radiation. So we have that as part of our research program. So this is just a schematic of the comparing our facility versus TJU. So at Jefferson, they do the lumpectomy, place the applicator in the operating room, and then that's in a ambulatory surgery center. And then once they've recovered, the patient actually basically walks over with the applicator in place across a couple grimy blocks in Philadelphia, and then has their treatment done in my old stomping grounds. So it is definitely distributed, and there's some food carts along the way and stuff. So it's real, it's urban. So one thing that's been interesting is that we've seen extremely rapid accrual on these studies. Like, patients are extremely enthusiastic. It's been a tremendous institutional win in our primary service area for patients. And it's really interesting, and it does tell you something about patient interest in IORT in general. As of Friday, we treated 207 patients, I told you, but this is like nothing at UVA has ever accrued like this. Shayna's got a lot of clout in the cancer center now as being the PI of this study, and I wish I'd held on to it now. But our challenges, so I would say a few things that we're very aware of and that I think are shared regardless of the method, and just sort of IORT specific. So research funding is a challenge, and we have just above the pay line, our R01 application. They're waiting to hear if it's going to get funded or not. But part of the criticisms, just from a grantsmanship perspective, is that it's perceived as relatively niche, or it's perceived as not standard, and so why are you bothering? Or the reviewer will say, well, these are patients that really don't need irradiation anyway, so what are we doing? So it's really challenging from a couple different perspectives. The other is that reimbursement. So we currently, because of the way the CPT codes are worded, it's either X-rays or electrons, but not gamma rays. So although a gamma ray is an X-ray to the body, photon's a photon, we can't bill for that. So we bill for a single fraction of 2 to 12 channel brachytherapy, which is not much. It really doesn't pay much. So this, from a sustainability perspective, it's currently not sustainable. And even in terms of centers conducting clinical trials, because usually when you're in a cooperative group study or something, you still get paid for the therapy you deliver. It's a big challenge. We've had a lot of discussions with our state payers and are working on that, but I think in the absence of a new CPT code, it's really challenging. Our multidisciplinary team is costly, so usually for IORT, it's the radiation oncologist going to the OR. We bring the OR to us. So we've got a surgeon who's in another location because we're separate from the hospital. We've got an anesthesiologist who can't cover multiple rooms, who's only covering this case. And then we've got basically OR staff over. So it is extremely costly to the medical center. The numbers have been looked at, and supposedly there are enough incremental patients based on this. Our overall breast volume is up, that is still viewed as a net positive for the medical center. And I think that the guidelines are currently, we share the pain because we're also not able to have a lot of trouble getting payment. And also I think from grantsmanship it's tough. We also anticipate that in order for anyone else to adopt this, we really need to complete a phase 3 trial. Because of all these considerations before, like reimbursement and grants and stuff, and just the amount of personnel effort required, we do anticipate a hard time, regardless of the form for the phase 3 study, in finding enough centers that are willing to bite the bullet and do this very labor-intensive program. So thanks to the UVA's team overall, it's a huge group of people at this point. Our faculty in radiation oncology has since grown, so thankfully I don't have to cover all these cases now. But the surgeons are all very supportive. They really, all three of them accrue equally to this. Pictured in the eyeglasses is our clinical care coordinator, whose basically full-time job is to help with scheduling for these patients. There is a little bit of a it's become almost a destination care within our area, and we've had a few patients even come internationally. So there's some level of sort of concierge trip planning that goes on as well, and the clinical research coordinators, of course. And then I would say within the UVA Cancer Center community, not just the faculty and research administrators, but the patients and the patient advocates have been extremely supportive of this overall program, and it's really affirmative that it's a good area to be working in. So, thank you.